Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we have a distinguished panel joining us to discuss an important legal decision resulting in acquittal of an anesthesiologist slash critical care physician on 14 counts of murder and attempted murder charges less than 2 weeks ago after he prescribed very high doses of fentanyl in the setting of so-called palliative extubations for critically ill patients. Under his care, admitted to an ICU at Mount Carmel West Hospital in Columbus, Ohio, between the years of 2015 to 2018. It's an important decision impacting end-of-life care, focusing on the concept of what we know as comfort care. Also determining criteria when a patient is terminal or medically futile, but also how to ethically conduct a palliative extubation in those that do desire withdrawal of life-saving care. Joining us to discuss this case is Dr. Lewis Nelson, Professor and Chair of Emergency Medicine at UMDNJ Rutgers with expertise in toxicology. Also joining us is Dr. Fred Merarkey, an Associate Professor of Emergency Medicine and Director UPMC Hammett, and an expert in end-of-life care. And finally, we have Dr. Thaddeus Pope, an attorney with expertise in medical law, bioethics, patient rights, and decision-making. I want to welcome everyone. Thank you again for joining me. Dr. Merarkey, I would like to begin with you. Can you explain what a palliative extubation is to the audience and how it's typically performed, who participates, and what are the mechanics of the procedure?
Palliative extubation is essentially a time when we decided we're going to withdraw at that form of life-supporting intervention as far as a ventilator, and we would remove the endotracheal tube and allow that patient to die naturally. What is typical can vary, and it varies according to provider background, training, level of comfort, and so on. And it's not something that emergency department physicians are typically comfortable doing, but we do it, and it's something that really came to a head at the time of COVID, as far as having to board patients and essentially being stuck with limited resources and so on, where we essentially had to do that procedure inside the emergency department. You have to have consent on the part of the patient, or the right documents in place, such as living wills or post documents, to essentially facilitate that conversation and decision making. But again, I think the big issue here is the issue of consent and making sure everybody's on the same page as far as the expectations that are what to be done. Now, I've done this procedure myself. I've done it many times myself. I've seen other physicians do it. I've seen physicians do it very well. I've seen physicians do it very poorly. So as far as what's typical, you essentially prepare. You prepare the family, you prepare your team, your nurses, any training physicians that you have with you as far as residents and so on. You get respiratory involved, and then you very calmly go about your procedure as far as providing some sedation if needed. And I've seen people do it with no sedation. I'm not really a fan of that, but I've done it with sedation and essentially asking respiratory to remove the tube, and then essentially having support there for the family as that patient dies naturally.
And some of these patients are near death. I mean, we're talking about pressures that don't even have a systolic pressure, that are almost like basically don't have any palpable pulses, that are apneic, that are grimacing, that are clearly in distress. So Dr. Nelson, so in a patient who is, say, grimacing or clenching or showing signs of distress, having difficulty breathing, there's a type of a dose of fentanyl maybe to give with midazolam, and there's a dose for others that are clearly not as actively having difficulty breathing, and that are almost nearly moribund. So maybe you can discuss that and what your thoughts are, and then put that in light of what this doctor, Dr. Husel, administered.
Yeah, sure, and thanks for having me here. I think we started during COVID to go in earnest and perform palliative extubation in the ED because of boarding and others that have already been commented on. We did use a palliative care team with some expertise in this. Most of the time before that, these were done in the ICU and other places. So we did sort of work our way up to performing these more often, and we implemented some protocols that had been used in other places, and we were learning a little bit more about how to make this happen. I mean, but clearly the idea here is to keep the patient comfortable as they're being extubated, and to make sure that the family doesn't witness any distress that the patient's having. So as part of our protocol and others, you would typically give a couple of medications, one perhaps to dry secretions if they were occurring, and one to sedate the patient, and one to get rid of the patient's dyspnea, their shortness of breath, which was a big part of dying that was very uncomfortable for families to watch and very uncomfortable for patients who experienced. The medication that we used to get rid of the dyspnea and to provide some sedation was fentanyl, and that was very typical, or morphine, an opioid, one or the other. And probably more typically people would use morphine, but there's no reason you couldn't use fentanyl. And a typical dose of morphine would be, 5 milligrams or 10 milligrams, enough to take the edge off of the shortness of breath and the anxiety, but not enough to slow their breathing to the point at which it stops or becomes unable to sustain life. An equivalent in fentanyl doses would be in the 50 to maybe 100 microgram range if you do the relationship between morphine and fentanyl, and either of them is fine. Probably any opioid would be fine. And often they give a benzodiazepine like midazolam to top off any anxiety the patient was having. The doses administered in the case, at least as it was reported, were in the range of 500 micrograms of fentanyl, not 100 or 50 micrograms, up to even 2,000 micrograms of fentanyl. Virtually no person, including those who have deep dependence on opioids, who are on long-term care for pain, or people who use illicit opioids, could tolerate a 2,000 microgram dose. It's just exceedingly high. When you're undergoing operative intervention for heart surgery or something, a dose of 500 or 1,000 micrograms would be more than enough to get rid of all of your pain. Right. So these doses were just way higher than anybody would recommend for a sedating dose.
So what would be the clinical effects of giving someone who's opiate naive or even had been on some opiates 500 micrograms of fentanyl, or even up 1,000 micrograms? Let's say has a systolic blood pressure of 70, 50, going downward further, is dyspneic, certainly, not in distress in that sense. Like, what would your expectation be?
Well, one of the nice reasons to choose fentanyl is that it is much more cardiovascularly stable than morphine. Morphine does tend to lower blood pressure and have some other effects. So fentanyl is better. I wouldn't have that much of a concern for the blood pressure and pulse. I mean, it might drop a little bit, but clearly the way that opioids kill you is by suppressing your breathing. Right. And obviously, when you're not breathing, you're not oxygenating, and you're not blowing off carbon dioxide. So both of those over a short period of time lead to a fall in blood pressure and other cardiovascular complications. So I would have every expectation in somebody that got 1,000 micrograms of milligram of fentanyl IV at once that they would stop breathing and all of those other complications.
And this doesn't happen immediately. Fred, you could attest to this. Thaddeus, I'm going to bring you in a second, but this could last, this could happen in 20 minutes. It could happen in 6 hours, 8 hours. Some studies have shown like a median of 8 hours until some patients die. That's why we try to have them from the ED up to a patient floor with family and so forth. Some patients have lived a week. The studies vary. So it doesn't happen in an immediate fashion. So this brings into the effect the double effect principle, that you want to make a patient comfortable, give them comfort care. But the secondary effect could cause harm. And so Thaddeus, this brings in this legal principle, the double effect principle, that our audience should understand that in this case, the prosecution was trying to say that essentially that Dr. Husel, what he was doing was in a sense euthanasia, that it was not the double effect principle that he was working against, or working on rather. And how would you respond to that?
So Dr. Husel was charged with murder and attempted murder, which requires the jury to find both that those doses caused the patient's death and that Husel's intent was that those doses caused the patient's death. Now, the jury acquitted Dr. Husel, so they found that either intent or causation or both were lacking. But the nature of the doctrine of double effect is that causation is okay, right? So it's absolutely okay that Dr. Husel could have admitted, yes, I knew that dose, 1,000 micrograms, 2,000, would cause the patient's death, but that isn't what I wanted. That isn't why I administered it, right? I administered it to keep the patient comfortable. That was my intent, was to keep the patients comfortable. And the nature of the doctrine of double effect is, so long as you intend the good thing, patient comfort, alleviation of pain and discomfort, it's okay that you know, even to a certainty, that your action will cause, the bad thing, the patient's death.
You don't expect death, but it can happen, and that's really what you're trying to say.
Well, it's okay. I mean, actually, the doctrine is actually robust enough that you can say, I know that it might cause their death, but it's even strong enough to say, I knew that it probably would, or even most definitely would cause their death. That's still okay under the doctrine of double effect. Because and this is codified even in Ohio law to say you have immunity from criminal and civil liability, because we want physicians to be comfortable. We don't want them to be chilled from administering what they deem to be the appropriate amounts of pain medication. So
And the question is, how will this impact, going forward, end of life care and comfort care? And I wanted Fred and Lewis to, jump in here. And, in your view, clinically, when you work a shift, are you going to think about this, or have you been thinking about this in any sense? Because this is, again, Dr. Husel is an outlier. This is not, in my opinion, how 99.9% of physicians who work in EDs, ICUs, or, in light of their anesthesiology, critical care, pump crit training, how they approach this type of procedure and this type of patient. And I'll let you start, Fred.
So as I mentioned, I've seen various ways people do this. Some is very appropriate, some is very inappropriate. And when you look at it, when people start taking these mega doses with an intent, it's a different way to practice. I've seen everything from someone giving somebody 20 milligrams of morphine every 3 minutes until they stop breathing, to someone just generally and just gently titrating to do it with respect. And I think that's the issue here. And will it stop people? I don't know, because it may be in the moment right now and people may think about it, but I don't know that this would actually stop anyone from their typical practice pattern, especially that they found him not guilty. So essentially it'll have an effect. I just don't know how big of an effect.
And Lewis, how would you?
Yeah, I mean, I think it's going to have mixed effects also. On the one hand, I could see there are docs out there, and a lot, I believe, that feel that these patients sort of deserve to die with dignity on their terms, right? And if the family and the patients made a decision, why do I just want to continue to provide comfort care when I could end their suffering, right? And effectively, I guess that might comport with the doctrine of double effect, or it might be considered euthanasia, depending on intent or whatever the motive, whatever the underlying issues are. But I do think it does raise within some of us the idea that people are watching, right? We're going to be under scrutiny for some of our practices. A lot of doctors and others do want to end suffering, but knowing that they're going to be scrutinized for the work that they do potentially, and we've seen this with the nurse out in Tennessee case as well. There's going to be perhaps people thinking twice about the activities they do that might actually bring scrutiny upon them, particularly if there's risk of legal proceedings.
Right. And I guess some of the scrutiny, again, obviously wasn't just on Dr. Husel, it was on the nurses, it was on the pharmacists. There were multiple people that were suspended, their licenses. In any event, the question is, the electronic medicine cabinet, the PICSIS, and involving an ED pharmacist and ICU pharmacist in these sort of non-emergent palliative extubations, where there was an override. In other words, the pharmacist wasn't informed, the nurses didn't go to the PICSIS and get the meds. These were verbal orders that in many cases he gave to just administer. And then there was, they were complicit in giving the meds in a lot of the cases until someone started to speak up, whether it was a nurse, pharmacist, to say something. And that's important because, someone, spoke up and said, there seems to be an issue here with the aggressiveness of the dosing. So, the ultimate question is, what guardrails and what, sort of safety features and other aspects of cultural change should we start to implement?
So I think the big thing it has to start with is appropriate policies, procedures, and training. If you think about it, for an institution to do this, they should have something in place that's a guideline. And essentially part of that guideline really should be on the part of the family to give consent. And then when that consent is given and appropriate, then to essentially follow the policies and procedures, standardized dosing. And when those dosings come out of standard, then they should be questioned. There's no doubt that, and I think Dr. Lewis, you said this, as far as the dose, giving someone a gram of fentanyl or 2 grams of fentanyl, I mean, that's immediate. That's not even a question. And it's very inappropriate. So I think anything that should come out of that standard policy and procedure should be questioned and brought to another level for oversight or approval and so on.
Right. And Lois?
Yeah, I mean, I think there's got to have to be a national conversation about a lot of these issues. Whether we're talking about medical aid in dying for certain populations, or frankly euthanasia, the issues that came up over the past 20 years about things like death panels have really kind of pushed people's buttons, and it's always a little bit surprising to see who falls on what side of an issue. Whether it's a religious or an economic decision, whether it's medical or otherwise, these are very, very complicated issues, which I think we've not done a very good job really working our way through in the country. And it's to some extent it's a state by state issue. To some extent it's a national issue. There's insurance implications and all these other things that go along with it. I mean, part of the conversation has to be how what Dr. Husel did, for example, is different than some of these angels of death, or some of these folks who, perhaps well-meaning, gave patients things like paralytics in the ICU in order to hasten their death. And and I don't necessarily want to equate the two directly, because the jury's spoken in this case. But again, it does raise a lot of questions about what we think is right as a culture, or even within subcultures across the country, how the time of death should be managed. And we've all seen people who really have no functional life left still having repetitive visits to the emergency department from a nursing home, who really sadly probably are suffering, and are expensive, and they consume a lot of resources, and we have a limited amount of resources in the country to spend on healthcare. And when we're spending it on people who are insalvageable and suffering, it just raises a lot of issues. And so you can see why people might think that what he did was okay, or what Angels of Mercy have done in other settings.
Right. And the jury did speak, and so and you've been quoted on this previously in other articles, that this is what people do want. This is what, when you have a full jury that unanimously agrees that he didn't, quote, murder 14 patients, it says something. And so I was a little surprised by the verdict. Other physicians were, my colleagues. Again, had they gone for a lesser charge of murder, and I'll bring this, that is, a criminally negligent homicide or reckless homicide, could they have gotten a conviction here? And that's something we don't know. We'll never know. But in your estimation, how would that have, played out?
Well, I mean, first, he did get acquitted on the criminal charges, but just remember, for context, he was fired back in 2018. His medical license is suspended. His DEA registration is suspended. He's facing a lot of civil lawsuits. I mean, so there's a lot of other, he beat the criminal charges, but there's a lot of other sanctions that he's bearing, and will continue to bear. But the prosecutors did try to go for reckless homicide as a lesser included charge, right? So what they had hoped was, if the jury doesn't find murder, then they would hopefully find attempted murder. If they didn't find attempted murder, then they would drop down to reckless homicide. The judge did not instruct the jury on reckless homicide, and that actually is because of the doctrine of double effect, because he's immune, right? If you allow the jury to conclude that he didn't intend their deaths, but he knew that his conduct was likely to cause their deaths, that would eviscerate, right? That would eviscerate the doctrine of double effect, which is codified in the state of Ohio, right? Because the legislature of Ohio is expressing the public policy of the citizens of Ohio, that we want our doctors to feel comfortable providing what they think is appropriate pain medication. And we don't want them to be chilled or scared from doing that. So as long as they're doing it with the intent of addressing the patient's comfort, it's okay that they know it might or will cause the patient's death.
And I think, right, and it's a very important point you bring across, the intent here being that, that he did not intend to, in other words, euthanize these patients was their verdict or their, what they came to decide.
So it's worth noting that let's say the judge did instruct the jury on reckless homicide. He didn't, but had he, it's not clear the jury would have come back with a guilty verdict on that, because it's, notwithstanding Dr. Nelson's points, it appeared that the jury was uncertain whether the drugs caused the patient's death, which is still an element. Even if you take out the intent element, even on the reckless homicide, they still need to show that Husel's conduct caused the patient's death. And it's not clear that they were convinced beyond a reasonable doubt that it did, because these patients were already dying.
The issue of accelerating a death versus causation of a death, there's a fine line.
If you contrast, you contrast it with the recent Redon Devat verdict, right? So she was convicted of reckless homicide, but there the causation part was easy, right? Because she was supposed to have administered a Versed, an anti-anxiety drug, but instead she administered a paralytic drug. So it's very clear that her conduct caused the patient's death. And so on the causation part, that case was easy. This case, way more difficult on causation.
Maybe you could just review what reckless homicide and criminally negligent homicide, how does that differ? What's the main, differing issue between murder, second-degree murder, on which they were trying to get him on, or first-degree murder?
So for murder, they don't need to show motive, right? So they don't need to show why he was trying to do it, but the prosecution did need to establish beyond a reasonable doubt that Dr. Husel, by administering those doses, wanted to cause the patient's death, right? And they were unable to convince the jury of that. When you move down from murder down to reckless homicide, you don't need to show that kind of intent. All you need to show is the physician proceeded in the face of a high probability that his conduct would cause it. So he didn't want it to happen, but he should have known that it would. So it's like driving 100 miles an hour. Maybe you don't want to kill anybody, you don't want to get in an accident, but by driving 100 miles an hour on the highway, you know that that's very, very likely to happen. And then negligent is an even lower bar, where you just make a mistake, or maybe a series, as in Redon Devat's case. It was a series of mistakes. So she intended the best. She really wanted to help her patient, but she pulled the wrong drug from the Pyxis. She didn't look at she made so many mistakes in a row that the jury found that was
right,
negligent or grossly negligent because of the number of mistakes that she made.
And that also brings up system errors versus, in other words, individual or provider errors. And that was a big part of, and still involves, some system errors, but this case, no doubt, with the pharmacist involvement, overrides and things in the setting of these palliative extubations. So
in both these cases, it's worth noting, right, that all of the spotlight, the public media spotlight shone on Redon Devat, the nurse, and shone on William Husel, the doctor. But in the background, of course, CMS, sent, basically threatened to shut down both these hospitals, right, because they had, imminent patient safety issues. But if you look at what the regulators were doing, the regulators weren't focused so much on the individual clinicians. They were focused on the entities and on the processes that allowed this to happen.
Exactly. So I want to wrap this up. Maybe each of you could give a few points, just take homes from this case, and what you think our audience should remember. And Louis, I'll start with you.
I think that I've said this before, but I think it does just open up a whole new area of conversation that we have to have about what we as physicians and the healthcare system believes, what patients and communities and populations believe. and how we should be managing end-of-life issues. I am concerned about the optics of palliative care, particularly in this case, just because of the doses that were used. Again, what his intent and motive and other things were, notwithstanding in the jury's decision, I think these doses are just too high to be utilized on a regular basis. And I just hope we don't walk away from this thinking that these are the right doses to be used. They are unquestionably likely to end in a fatal outcome, as they did in this case. Statistically, maybe if one of these patients happened to die the moment the tube came out and they got the medication, and the rest did fine. But when you have this many of them pulled together, it just speaks to me that the statistical chances of these all being coincidental with the extubation, it just seems very unlikely.
Right. Okay, Fred, and a few points from you.
I copy that as well. I mean, I think no one should take from this that this was an okay dose to give. This is not an okay dose to give. And appropriateness needs to be called into question here. And policies and procedures at institutions need to be put in place so that there's a guideline for providers to act on, and then subsequently have consequences if they don't act upon those policies and procedures appropriately. Or there's got to be a reason that they want to take some superhuman dose that'll kill a horse and give it to a patient. It's a respect issue. There was a lack of respect that was applied here. And I hope that people will still do what they need to do for patients and not let this type of an outcome affect them, but they still need to bring it into reality and use it with appropriateness.
Thanks so much. And that is,
I would just say that this is not really new when you zoom out a little bit, right? For a long time, we've talked about the tension between giving patients appropriate pain medications and physicians fearing criminal or regulatory investigations. And the way that we balanced, right, those two, the physicians getting caught in that vice grip was good documentation, right? So maybe 2,000 is never, ever sufficient, but there's going to be a gray zone, right? I don't know exactly the right number. And we don't want physicians to be chilled or deterred when they think that's appropriate. But you're going to have to document, if you're going up to 500, why 200 wasn't sufficient, or whatever the right numbers are, right? Start with the lower dose, document that it wasn't sufficient to alleviate the dyspnea or whatever discomfort there was, and then go up to a higher dose. This is what we do in the outpatient setting, and I think that's a way to resolve the tension.
Yeah, I want to thank everyone for this excellent discussion. Very difficult, obviously, topic to talk about, but again, with respect to all the families, thank you again, and much appreciated.